Well, For the weekend. Yeah.
Just send them away and say this is like.
Yeah.
There will be like interruptions for questions during the. This is the end.
It'll be in the chat. You just.
Oh, sure. No, I just hit the screen part and it kind of exploded. Oh, just like that.
So great.
Are you nice touch? Did you do this or did they send you that?
No, I think I did.
Personal touch.
Yeah.
No, no, no. How do we,
Thank you.
For the ends or for this?
Okay.
Should I get started then? Do we have any? All right, everyone's got food. We are going to get started. Thank you all for joining today. Just to be clear, this is our What's New Addiction Medicine talk. This is not M&M rounds. This is better. I'm glad you're here. We have better food and better content. That's not fair. Good content. That's not. I don't know who's doing it today, but in any case, my name is Paxton Locke. I am the program director for the fellowship program, and welcome to our last What's New in Addiction Medicine for this academic year. I'm very pleased to introduce Dr. Jonathan Athayde today, who's going to be talking to us about a topic that's near and dear to my heart. As an internist, I can't help but note there are more admissions to hospital per year in Canada for alcohol-related complications than there are ACS for heart attacks, and yet we're still in the dark as far as really evidence-based strategies for managing these presentations. So I'm very excited to introduce today's topic. Dr. Athayde is one of our GIM fellows. He previously did his GIM residency here, his internal medicine residency here, and is now doing his GIM and addiction fellowships. He is going to follow this up with further training in critical care out in Toronto, starting next year. And has an interest in the intersection of withdrawal management and critical care. He's going to be talking to us today about a review of alcohol withdrawal symptom treatment, a historical perspective of loading versus symptom-triggered benzo protocols, barbiturates, and beyond. Extra points for the alliteration.
Thank you. Thanks for the introduction. I also like to give special thanks to Dr. Dennis, who's helped me so much with the research that's gone into this presentation, and for the research presentation I'll be giving at the BCCSU conference this weekend. Shout out to that. And George, who is a medical student at Hamilton. He was here working as a nurse when I started, and he'll be an eMERGE resident starting in July in Toronto. So to start things off, I'd like to respectfully acknowledge that I'm a humble guest on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflict of interests. And the objectives today are to understand the history of benzodiazepines and their role in the management of alcohol withdrawal syndrome. And we're going to be talking about different protocols for the use of benzodiazepines, but focusing really on front-loading protocols, and review the literature to date about their administration and the treatment of alcohol withdrawal syndrome. And so, as Paxton said, there is a very high prevalence of alcohol use disorder. This is a lifetime prevalence of alcohol use disorder. 29% of people will, at one point or another, identify with potentially meeting that diagnosis in their life. These individuals have a very high rate of health utilization services. This is a statistic for Canada. 6.3 out of every 1,000 ED visits in 2020 at the beginning of the pandemic were related to alcohol use disorder, alcohol withdrawal. And it's a very serious condition, especially when people enter into complicated withdrawal. It's potentially a life-threatening condition with things like seizures, delirium tremens, and death as a consequence. And even beyond the life-threatening consequences, there are other serious health consequences that extend hospital stay, such as hallucinations, delirium, ataxia, falls, and the consequence of falls. and Wernicke's encephalopathy. And can we close that door? Thank you. And you know, at a very broad level, we talk about the pathophysiology of alcohol withdrawal being this imbalance between neuronal excitation and inhibition. Okay.
Oh, it's okay.
Okay.
That's
Where you know, in physiologic or balanced state, there's a balance between GABA, which is an inhibitory neurotransmitter pathway, and glutamate, which is an excitatory neurotransmitter pathway. And when people are exposed to alcohol, which is a CNS depressant, for a long period of time, that resets the balance to upregulate the excitatory pathways. And when you remove that depressant, people fall out of balance, and that is what causes the alcohol withdrawal syndrome. And to get even more specific, sedative hypnotics and alcohol enhance the GABA inhibitory chloride channel. Like I mentioned, chronic alcohol exposure downregulates, and in some in vivo studies is thought to desensitize the channel by changing the percentage of the subunits, specifically alpha-1 subunits, get switched out for alpha-4 subunits, where alpha-1 is where benzodiazepines actually bind. And then in terms of the treatment and interaction with this channel, benzodiazepines modulate the frequency of opening the channel when in the presence of GABA, and then barbiturates increase the duration that the GABA channel is open. They also inhibit glutamate release by interacting directly with an AMPA, another excitatory receptor, to inhibit glutamate release and thereby reduce the amount of excitatory load in the system. And they're not as inhibited by those desensitizations that come from chronic alcohol exposure, such that benzodiazepines are. And this is all manifested in the alcohol withdrawal syndrome. So this is kind of the characteristic, more mild form of alcohol withdrawal, with things like, still very troubling things like hangover, night sweats, shaking, paranoia, potentially extending into hallucinations and delirium. But after that first 4 days, tends to start to resolve. And then in the more serious form, the more serious complications that can occur are seizures, hallucinosis, and delirium tremens, with potentially life-threatening consequences, ICU admission, intubation, things like that. So who is at risk? We have a tool that, if you consulted the AMCT service, we put it in a lot of our consult, called the PAUSE score. And where this actually came from was a systematic review and meta-analysis in 2014 by an author and a group of researchers that we'll actually be talking about today, that combed through the literature and actually identified features that are associated with higher risk of complicated alcohol withdrawal. And so 233 articles were included in this meta-analysis, and they distilled this into 10 unique clinical features that, if you have at least 4 of them, the sensitivity, specificity, positive and negative predictive value of actually having alcohol withdrawal in some form approach 100%. It's a very useful score, and that's why we use it. That is what it looks like. I won't get into nitty gritty of this, but not all of these features are created equal. Not everyone that scores 4 on this tool will go on to require benzodiazepines or have seizures or have that complicated withdrawal. But it's the tool that we use to start thinking about implementing some form of treatment, whether that's benzodiazepines or other things. This is what we use. And so, once we identify who is at risk of alcohol withdrawal, like how did the treatment come about? And we've been thinking about alcohol withdrawal for a very long time. It was first characterized in the 1950s. A few researchers started to actually go out and characterize what is actually associated with people who have alcohol withdrawal, the specific symptoms. And at that time, sedative hypnotics were first started to be used in the treatment, mainly barbiturates upfront, but then some studies started to come out that looked at benzodiazepines and showed some effectiveness, although literature back then is not what it is today. Moving forward into the 1970s to 1990s, that's really when we started to see a lot of people start to look at benzodiazepines as a potential therapeutic tool. And they also started to characterize all these different protocols, fixed dose, symptom-triggered, front loading, which we'll get into in a second. But also at this time, other therapies were investigated. Anticonvulsants took up a lot of the literature because of that concern of seizures. And we'll talk about, what the current recommendations are, but certainly it was investigated. And then from the early 2000s onwards, benzodiazepines are recommended as first line of therapy in alcohol withdrawal syndrome. And, as most of you probably know, symptom-triggered therapy is a preferred therapy because it's associated in the literature to date with lower cumulative benzodiazepine administration and generally non-inferiority in terms of adverse events. That is to say, people are treated adequately for their withdrawal with lower rates of benzodiazepines, and we don't see more seizures or DTs or death. At least that was the guidelines as of 2000. And today, like, why benzodiazepines? It's the most studied medication to date, and in the ASAM guidelines, benzodiazepines are the preferred therapy for alcohol withdrawal. They've been compared to all those other therapies that I talked about, anticonvulsants, gaseous anesthetics, antipsychotics, things like GHB, and they've been found to be either no different. Other therapies have either been found to be no different in terms of seizure prevention, specifically with anticonvulsants, but generally inferior with regards to other complications of alcohol withdrawal syndrome. And a systematic review in the 1980s characterized there being no significant difference between the different benzodiazepines used, but generally speaking, we prefer to use long-acting agents such as diazepam and chlordiazepam oxide for reasons that I'll get into. So these are a few of many potential medications that we can use. You'll notice diazepam, lorazepam. It's probably being familiar, the medications we use the most. For some of you, I think might be surprised to hear that diazepam actually generally has a faster time of onset despite being a longer lasting medication, both in the IV formulation as well as the PO formulation. And it does have an active metabolite. I forget the name. I think it's desmethyl diazepam, but I have it later on in the presentation, which has a half-life of up to 100 hours. So it's a really nice medication in that it is a treatment that you can give up front that will probably last for the duration of that dangerous period of alcohol withdrawal. However, we generally avoid it in severe liver disease, and it is renally cleared. So there is a role for lorazepam in populations that are frail, have liver disease or renal dysfunction. However, it has a slower onset of action, and so there is that potential for dose stacking where, if someone has severe withdrawal features, you can give multiple doses of lorazepam up front, and then you'll have oversedation later on. Midazolam, is useful. It's a short-acting benzodiazepine. There's not as big a body of literature looking at it, and certainly much less familiarity with using it in the emergency room setting or in the ward. So that's what I'll say. It's mostly used in the ICU setting. And then chlordiazepam oxide is medication that we don't use a lot. It's used quite a bit in the United States. And like I was saying, it is the benzodiazepine that has the biggest body of literature from the 1970s to like the 2000s because of familiarity with its use. But it was characterized as this long-lasting benzodiazepine. The half-life is actually shorter than Ativan, but it is, it's been most characterized in the outpatient setting in fixed tapered protocols. So what are the different protocols for benzodiazepine administration? The first is fixed taper protocol, which is fairly self-explanatory. You set a schedule for benzodiazepine administration. You don't deviate for it. And it's probably the most clear. The advantage is that, there's little room for interpretation. It can be used in settings where people have less familiarity with treating alcohol withdrawal syndrome, or there's less skilled nursing to actually assess alcohol withdrawal syndrome, or in the outpatient setting where there's no one to actually check in with patients and see how they're doing. But, it has the obvious disadvantages that it might miss the mark. People might be undertreated, and people might not be assessed for the severity of their alcohol withdrawal. That's in contrast to the symptom-triggered protocol, CIWA-Ar being one of many tools that's used. But essentially, the ethos of the protocol is that people are assessed at fairly specified intervals for the presence of alcohol withdrawal syndrome, and then they're administered benzodiazepines if they meet a threshold in terms of the severity of their withdrawal. And then front-loading protocols, which we'll talk about today, are the principle of it is to give a big enough dose of benzodiazepines, either driven by symptoms or not driven by symptoms, depending on the protocol that's used, in an attempt to get ahead of withdrawal syndrome or to treat very severe withdrawal syndrome as measured by different alcohol withdrawal scales. And we'll talk about what that might look like. In terms of withdrawal scales, specifically, this is one that you must all be very familiar with. The CIWA-Ar, the CIWA-A, I think, was developed in the 1970s and had many, many more questions. I think it had like up to 20 questions or something like that. And so the scores could be very inflated. It had things like hallucinations in addition to auditory disturbances, visual disturbances, as well as seizures being a part of the protocol. And so in 1989, they pared down the CIWA-Ar based on a systematic review of the literature and identified the key features on interview and physical exam that were associated with high risk of withdrawal, and took out a lot of those extraneous things that made it more challenging to use. But that's not the only one. There's lots. There's brief alcohol withdrawal scale. There's the RASS that's commonly used in the ICU or Richmond agitation and sedation scale. There's a SHOT scale, which comes up in some of the studies. But ultimately, CIWA-Ar is the scale that has the biggest body of literature, and therefore, it's validated. We understand better how to use it and how to score people's severity using this scale because it has the biggest body of literature. So how do we at St. Paul's, and for those of you that work at BGH or elsewhere, use the alcohol withdrawal scale? I apologize, it's probably hard to see, but in terms of the actual frequency of scoring, upfront, when you implement this protocol, people get scored Q1-hour until their scores are below 10 for 3 consecutive readings, and then it extends to Q8 hours. And if they have severe withdrawal, they're monitored more frequently. They're not necessarily given meds on a Q30, not Q3 minute basis. That's a typo, but they're monitored quite closely. And then
Your attention, please. Would Leah Boomer please return to Unit 7 Alpha?
In terms of,
Boomer,
I'm just going to wait.
return to Unit 7 Alpha. Would Leah Boomer please return to 7 Alpha?
In terms of the actual implementation, people can be given doses of either diazepam 10 to 20 or lorazepam 1 to 2 Q1-hour, as long as they continue to score on the CIWA. And that's important to remember when we start talking about how loading dose protocols are defined in the literature. But this is what we do at St. Paul's. So the knowledge gap, would administering a front-loading protocol prior to the onset of withdrawal or when alcohol withdrawal emerges reduce the risk for dangerous sequelae and promote a shorter length of stay? Does the idea of getting ahead of withdrawal with a big dose of benzodiazepines have merit, and has it been studied in the literature? And that's the knowledge gap that I've tried to address, or not me, I'm the tail end of many people that have worked on this project ahead of me, Dr. Dennis being the champion, but that is the gap that we're trying to address with this systematic review. And so for this review, we included a wide body of different databases in order to capture as many studies as possible. We looked from the time of conception of literature up until 2020, when the review of available literature closed, when we had identified all the studies that were going to include in the study. And then me and George reviewed, did the full extraction from the studies that were identified by the rest of the authors. And these are the operational definitions for fixed dose, symptom-triggered therapy, and front loading. I think fixed dose and symptom-triggered we've already kind of fleshed out, but front loading, we're we were hoping for at least 40 milligrams of diazepam. We were hoping to include protocols that allowed for at least 40 milligrams of diazepam to be given up front, or in a short time period, that is to say less than within 4 hours, or constant infusion of benzodiazepines in conjunction with additional benzodiazepines as a loading strategy. Inclusion and exclusion, we looked at adults. We didn't put a restriction on the types of protocols or the types of studies that were included in the systematic review and meta-analysis that was to be, but wasn't. So long as they actually assess the front-loading protocol, and yeah, all the study designs were accepted. I'll gloss over this to say that there were initially 701 studies that were identified in the search strategy, 381 after duplicates were removed, and in the end, 10 studies were included for the review. If there's questions about the search strategy, I'm happy to address them at the end. But in the end, we identified 4 randomized controlled trials, 3 retrospective cohort studies, 2 case series, and 1 database cross-sectional cohort study. And these are the loading dose protocols described in the literature. I apologize, it's a very busy slide. I'm happy to dig into the details, and we will when we look at the results. But this is just to say that there's a very wide variation of loading dose protocols that are described in the literature. And this is just to highlight kind of a philosophical divergence in loading dose protocols that are described. And you know, the ones that were closer to meeting the definition as we had specified before are the ones highlighted in green, where, you know, at least 40 milligrams were given, potentially given within a 4-hour period. For example, you know, Lee et al. In 2019, their protocol was quite aggressive and could result in a maximum 150 milligrams of diazepam given within 1 hour, in addition to phenobarbital. In contrast to something like Day et al. 2004, which, you know, Q90 minutes CIWA-Ar, if their score is greater than 10, then they would get 20 milligrams of diazepam, which, you know, philosophically is very similar to what we do already for a symptom-triggered protocol. You know, why would that be called a loading dose protocol? Probably because diazepam was the medication that's used, and as we talked about, it has a long half-life and a long half-life of active metabolites. So even if it's administered in a symptom-driven fashion, it could result in effectively a load where people get a lot of diazepam that will last for the duration of their withdrawal syndrome. And getting right into the results, there were 4, let's say, categories of results that we looked at. The first was the duration of treatment of alcohol withdrawal syndrome, depending on the protocol that was used. The first study, Barbiturates et al. Was a case series that wasn't the best case series. The protocol that they used was effectively like a symptom-driven protocol, and they didn't really define what success or failure meant, just that 6 out of 14 people succeeded in treatment and didn't require more benzodiazepines, and the rest did. That's all I'll say about that. We included it mostly because it defined a loading dose protocol, and also to point out that there is significant heterogeneity in the definition of what a loading dose protocol is, and also to point out that, you know, more high quality research is required to better characterize the safety of this intervention. Day et al., like I mentioned, diazepam Q90 minutes for CIWA-Ar of greater than 10, kind of like a symptom-driven protocol compared to chlordiazepoxide in a fixed dose taper, was associated with significant reduction in duration of treatment. Day et al. Compared the duration of treatment with the load as defined by a consistent CIWA-Ar score less than 10 to be 8.2 hours, and compared that to the fixed taper protocol of 242 hours, which is the entire duration of the fixed taper protocol. So it's significant, but I don't know if that's a fair comparison. Like, I don't walk away with that saying that, like, I know that it's associated with better treatment of alcohol withdrawal syndrome. And in the study, when they actually looked at the statistical significance of the rate of change of CIWA-Ar, there was no difference between load, the front loading protocol and the fixed taper protocol. Maldonado and Associates looked to give patients included in the study a load of up to 60 milligrams, but over 6 hours, so slightly outside we're just barely meeting our operational definition of what a load is. They didn't see a significant difference in the rate of change of CIWA-Ar, the percentage of patients symptom-free at 72 hours. There's, a big difference in the percentage of people who are symptom-free in the front load over the symptom-driven protocols, but it didn't approach statistical significance. Sellers et al. Is probably one of the most referenced studies in this systematic review. It was an RCT that compared a load of diazepam up to 120 milligrams of diazepam upfront to placebo, which probably wouldn't get away with anymore. They didn't find a significant reduction in the duration of treatment, but they don't actually report what that was. They only report the Mancoba results. And then they go on to combine everyone who actually received benzodiazepines, which if people failed in the placebo arm, they got the benzodiazepines and then reported that result. But they thought that there was a reduction in the duration of treatment associated with the load. And then Welzewski et al. Looked at, again, more of like a flavor of a symptom-driven protocol. But they showed a significant reduction in the duration of delirium, 6 hours with a load versus 33.8 hours with local regimens not otherwise specified. So in summary, mixed results in the sense that there might have been some funny business going on. And so careful interpretation is needed. The loading doses might be associated with a shorter duration of alcohol withdrawal syndrome treatment, but more high quality research is required in order to say this definitively. The second category of results that we looked at was hospital length of stay, as opposed to duration of actually being treated for alcohol withdrawal. Like, how does treatment of alcohol withdrawal affect how long people stay in hospital from other things like delirium, falls, sedation, that kind of thing. That's what's extended into hospital length of stay. Liadel had a very aggressive protocol, which I'll get into the nitty-gritty of later because it's interesting. But I mean, if you look at their experimental arm and the control arm, both are very aggressive. Like I mentioned, for the experimental arm, people could get up to 150 milligrams upfront as a load, and then in combination with that phenobarbital. But in the control arm, they also could get diazepam 10 milligrams Q15 minutes for an elevated RASS score up to 120 milligrams. And even though this was characterized as a symptom-driven protocol, both could be considered front-loading protocol. But that being said, when they looked at outcomes for length of stay and ICU length of stay, there was a significant reduction in both. A pretty significant reduction in duration of treatment. I'd say a caveat to this study is that I think they were developing both protocols starting in like 2010. And so this might also represent a more streamlined and familiar state that the institution as a whole was with this aggressive treatment of people specifically with very severe withdrawal. But I think it's encouraging results, and as we'll get into, not associated with a higher rate of complications. Vital et al. Developed their own protocol for monitoring withdrawal called the MINDS protocol, which I'm happy to talk about. They use a different, the Minnesota detoxification scale. They developed their own scale with a bunch of intensivists, nurses, and other allied health workers. And so they compared this protocol to whatever was happening before they implemented this protocol at their institution. And it was also associated with a significantly reduced hospital length of stay, but not as significant, 3.37 days versus 3.9 days, which might be the time that patients need to find a ride home. So maybe the clinical impact is not as big, but there is a statistically significant difference between the treatment arms. But as we'll get into, this is also associated with a significant increase in the rate of adverse events. So in summary, in terms of hospital length of stay, loading dose protocols might actually be associated with a reduced length of stay, which is good. the third category of results, cumulative benzodiazepine administration. They et al. Talked about their protocol. They did see a significant reduction in cumulative benzodiazepine administration, 74 milligrams diazepam equivalents versus 233. They reported as chlordiazepam equivalents, but I think that is kind of what we expected, because in essence, this is still like a symptom-driven protocol, which in the literature we already know is associated with a lower cumulative benzodiazepine administration compared to fixed taper. Anyways, Patel et al., despite their aggressive novel new minds protocol, they didn't see a difference in the treatment groups and cumulative benzodiazepine administration, and actually like not a very impressive amount of benzodiazepines used in each arm on in terms of mean benzodiazepines. Well, Zuski, they saw a significant difference in their loading protocol versus local regimens. The significance was not reported, but the absolute values kind of stand for themselves. 90 versus 1,800 diazepam equivalents, which is crazy. And then finally, Steele et al. Is the retrospective cross-sectional database analysis, which identified relevant cases to be included in their trial based on the prescriptions identified in the veterans in the VA database. And so a fixed taper protocol, not to get into the nitty-gritty, but the definitions of the fixed taper, symptom-triggered, and front-loading protocols all match our own operational definitions for the different protocols. So we've kind of already talked about that, and they saw a significantly higher cumulative benzodiazepine dose associated with front-loading protocols, 355 diazepam equivalents compared to 208 for symptom-triggered and 182 for fixed taper. So, in summary, mixed results. Among the studies that showed a lower cumulative dose of benzodiazepines, most of these were studies that used a less aggressive protocol off the bat, something that is more in line with what we use here at PHC. And then finally, adverse events. Deveni et al. Was a retrospective case series. They were looking specifically at the rate of seizures in their patients with a front-loading protocol of up to 60 milligrams within 3 hours. And no one seized, and they didn't report any other adverse events. So it's a happy ending, but it's not a huge cohort of patients. Patel et al. With the MINDS protocol saw a lot of complications. No significant difference in adjusted 30-day mortality, but a significant increase in all-cause 30-day readmission after discharge, a significant increase in ICU admission and transfer. No significant differences in adjusted in-hospital mortality, ICU length of stay, or use of restraints, but reason to have concern about loading in a protocol that fits our definition of what a load is. People could get up to 80 milligrams at once, and this was associated with more complications. Lee et al., the coolest study in my opinion, with a very aggressive protocol, didn't see a difference in adverse events such as intubation, duration of ventilation, ventilator-free days, reversal with flumazenil. But that's with the caveat that both of these protocols are quite aggressive. And then finally, Steele et al. Saw that there was significantly higher adjusted predicted probability of ICU care and intubation associated with front-loading protocols compared to both symptom-triggered and fixed taper protocols. So in summary, in the majority of studies, front-loading protocols were associated with high rates of adverse events, including all-cause readmission, intubation, and ICU transfer. And then finally, there's a final study, Levine et al., that actually compared two different loading protocols with diazepam and lorazepam. This was triggered by a shortage of lorazepam at the institution during the time period that was specified. And what they saw was that there's no significant difference in terms of the actual rate of change or the duration of alcohol withdrawal syndrome treatment there was a significant increase in the rate of delirium, as measured by the CAM-ICU score. But there wasn't significant differences in transfer to ICU intubation, respiratory depression, hypoxia, overstation, hypotension, and treatment with dexmedetomidine. Obviously, this is all in the ICU setting. So, I mean, this kind of fits in with a broader body of literature that says that, you know, in eligible patients, diazepam, a longer lasting, quicker acting benzodiazepine, is better or is associated with less complications than lorazepam. But again, a retrospective cohort study with all of its flaws, difficult to draw causal associations, but associations for sure. And then quality of evidence. This is for the retrospective studies, the Cochrane risk of bias analysis, and you know, none of them were perfect. A lot of them had potential for risk of bias. Most of them randomized in a coherent way, but allocation concealment, blinding of participants, always challenging, blinding of outcome assessment, all of these, except for Sellers et al. But you know, the details of what Sellers et al. Was actually doing were a bit hazy. All of these had opportunities for bias to be introduced. And so this is, again, to say that the quality of literature to date is not necessarily where we want it to be to say definitively draw any definitive conclusions about the efficacy of front-loading protocols. And the same was reflected in the retrospective cohort studies and the cases. And so, I mean, a summary of what we found on front-loading protocols, they should be used with caution, given the high rates of adverse events. You know, the one advantage that we saw was possibly a shorter duration of hospital stay. But besides that, maybe not any clear definitive advantage over symptom-triggered studies, but certainly more high-quality studies are required, which is the conclusion of many systematic reviews. And so we've talked about a lot of these objectives. Where am I? Okay, we still have time. So some other therapies, gabapentin. I'll talk briefly about this systematic review, kind of as a broad or a short overview of the role of gabapentin in alcohol withdrawal treatment. This systematic review included 10 publications, 5 of which actually looked at the use of gabapentin in alcohol withdrawal, and the other 5 the use in alcohol use disorder. Briefly on pharmacology, it's structurally very similar to GABA, but it actually doesn't bind GABA A or B receptors, and instead interacts with presynaptic voltage-gated calcium channels to modulate excitatory neurotransmitters. That's a long way of saying we don't know exactly how it works, but it works. It's used in neuropathic pain, seizures, anxiety as a broad application of treatment, relatively short time to onset or time to peak, not as short as IV diazepam, but still not bad. Half-life not as long as other therapies, and it's renally excreted. So in this very sick population, it should not be used. And so I apologize, very busy study, very busy slide, but to go through the specifics, early literature looked at pretty low doses of gabapentin, 400 milligrams. Actually, that's not that low, 400 milligrams Q6 hours with a taper, and it didn't show any difference between people, I think, who actually forget what they were treated with. I think they were treated with benzodiazepines, and then they looked at fluoride oxide rescue doses, but there wasn't a significant difference between the groups in terms of fluoride oxide rescue, so not a positive study. But then they looked again in 2010 at a higher dose upfront of gabapentin, and for people who responded to that dose in terms of reduction in their CIWA-Ar scores, additional doses of gabapentin over the next 24 hours up to 2,400 milligrams. And they showed, a significant effect of gabapentin in the early responders compared to the non-responders in terms of resolution of CIWA-Ar scores. Problematic protocol, but some evidence to say maybe a higher dose of gabapentin upfront is useful. Merrick et al. Looked at 3 different strata of treatment of gabapentin in comparison to a lorazepam fixed tapering protocol, and actually showed that in the 1200 milligram group, there was a significant reduction in CIWA scores compared to lorazepam. This was not seen in the 900 milligram group. And in the 600 milligram group, they actually had to stop intervention early because of significant rates of adverse events. So this is possibly suggesting that, you know, a higher dose of gabapentin could be effective in more mild forms of withdrawal. In this study by Mariana and associates, GABA, pretty high dose, was compared to phenobarbital. And they looked at the proportion of treatment failures, and there was actually no significant difference between the gabapentin arm and the phenobarbital arm in terms of requirement of rescue doses of phenobarbital. So encouraging. And then finally, Stock et al. Compared gabapentin 1200 milligrams as an outpatient protocol to chlordiazepine epoxide. And they looked at things like cravings, daytime sleepiness. They didn't see a difference in terms of cravings, no significant difference in daytime sleepiness upfront, but gabapentin was superior to chlordiazepine epoxide in terms of sedation later on in the fixed taper protocol. So what do I take away from this? Gabapentin is probably useful at managing alcohol withdrawal at higher doses, greater than 800 milligrams up within 24 hours upfront in individuals with pure alcohol withdrawal and fairly mild alcohol withdrawal. It has been shown to be comparable to benzodiazepine fixed taper protocols, and you know it's usually given as a fixed taper. And it can be used fairly safely in combination with benzodiazepines as a rescue. There's lower rates of sedation, but it should not replace benzodiazepines in patients with high-risk complicated withdrawal, that is a PAS score greater than 4, and should generally be used by people with expertise in addiction medicine. And I think it's always important to consider the exclusion criteria for these kinds of studies. Things like dependence on other substances were excluded, positive UDS, previous DTs, concurrent use of other substances, cognitive deficits, commonly scoring on a MMSE less than 26. And in only one of the studies was previous seizures or seizure disorder and exclusion to using benzodiazepines, and that was in the Stock et al. Paper, which looked at outpatient management of alcohol withdrawal with gabapentin. So that's somewhat encouraging, but this is, you know, along with a bigger body of alcohol withdrawal syndrome, these are protocols that should be used in patients that don't have much else going on, like have pure alcohol withdrawal, don't have like concurrent opioid withdrawal, stimulant withdrawal, things that might interfere with assessment and emergence of symptoms. And then phenobarbital, the hot topic, especially 2012 onwards. Before getting into some of the literature, I'll just do a short plug of comparing phenobarbital to diazepam. You know, both have pretty quick onsets of action. Both have pretty long durations of effect, which is why we use them. And the half-life, surprisingly, between diazepam and phenobarbital isn't that different, especially when you consider that, there we go, desmethyl diazepam. I think I got it right. The half-life of desmethyl diazepam, you know, the half-lives could be comparable, but I think something that we don't necessarily consider up front is the sequelae of using phenobarbital. Sure, you know, it directly activates GABA receptors at high concentrations, so getting past the GABA deficiency aspect of severe withdrawal that's ICU bound. It blocks the AMPA kainate receptors and inhibits glutamate release. It's all great, but it's a very strong CYP inducer, and so that will have sequelae on the other therapies that patients are coming in with. And you know, at St. Paul's, we have a lot of people that have concurrent opioid use disorder, that have HIV, that have other comorbid conditions where the metabolism of these drugs will be affected by giving them phenobarbital. And you know, maybe you get over the hump of their alcohol withdrawal, but suddenly their methadone is not working as well because you've induced its metabolism. It's also contraindicated in porphyria. It can cause a severe porphyria reaction, which is cool. And then it has some endocrine side effects, which I won't get into. So I mean, this systematic review, it looked at a number of studies. I think there's also another 10 studies, and I won't go into as nitty-gritty detail. It was associated in these studies with a reduction in mean hospital length of stay. However, only 2 studies were included in that part of the meta-analysis. There's no significant difference in ICU length of stay compared to benzodiazepines, no significant difference in intubation. But, you know, the majority of these studies were predictably conducted in critical care settings. Many studies turned to phenobarbital if other sedatives were not available, like Precedex. And, you know, one of the worries with phenobarbital is its hemodynamic effects, and there was no association with bradycardia hypertension between the arms that phenobarbital was compared to. But once again, I think the same conclusion can be drawn that it should not replace benzodiazepines as a standard of care for alcohol withdrawal syndrome. And although there are protocols for it to be used safely, like in Victoria, they have a phenobarbital protocol for treatment of alcohol withdrawal syndrome, which most people use, and you know those individuals have experience with it. In Surrey, a lot of people use phenobarbital because there's a significant and much more severe population of alcohol use disorder in that population, and so you know people have familiarity with phenobarbital, but you know experience cannot be understated, both on the for everyone involved, for physicians, nurses, everyone, pharmacists in terms of the interactions, and so caution should be exercised. And that's all I have.
Thanks. Were there any questions in the room?
With all the literature that you've read, what would you do?
I'm just going to repeat the question for everyone online. With all the literature you've read, what would you do?
So, like I mentioned, I like the Lee et al. Study. And this is a prelude to explaining what I would do. They were looking specifically at people that had severe withdrawal, and they included people in their study if they received 30 milligrams of diazepam at once before. And they say that's a bit of an arbitrary cutoff, but if you actually look at their protocol, thank you. Complicated, but you know, to get to the 30 milligram dose, and this is a protocol that they were already kind of using at their institution beforehand. They developed it a number of years ahead of time. You have to have pretty severe withdrawal measured by the RAS and have failed responding to treatment with 10 milligrams to 20 milligrams ahead of time. So this is to say that they thoughtfully selected patients to be treated with an aggressive front load based on failure of upfront management. And they obviously had experience with using this protocol because they had a similar symptom-triggered protocol that was already being used at the institution for a number of years ahead of time. And so in patients that upfront have CIWA scores of greater than 20 and don't have other things going on like opioid withdrawal, stimulant crash, etc., I would consider a load. And I'd probably use something along this line, maybe not 60 milligrams up front, but escalating doses or rapid reassessments to see if there was treatment success or treatment failure. But those cases are few and far between. And I think that one of the big conclusions from this is that our protocol at St. Paul's, you can effectively be loaded with the CIWA score per the definition of what a load is, just by clicking the symptom-driven protocol on Cerner. So people can be loaded with a CIWA. And so I'd only use this in someone with severe alcohol withdrawal syndrome, without other things going on, without other significant comorbidities like old age, frailty, renal dysfunction, liver dysfunction, and probably if they've had seizures or severe withdrawal in the past that has been refractory to treatment. But it should also be noted that this also combined benzodiazepines with phenobarbital to have better outcomes. So that's what I would do.
on that note, do you like think there's a role for like low dose phenobarb with benzo protocols?
I think there's a role if, like I said, there's a lot of familiarity, like not only yourself, but the nurses and everyone else in that institution being familiar with phenobarbital. If you're asking if I would consider phenobarbital something useful here, I don't think so, and mainly because we have a very complex population that has concurrent disorders, concurrent psychiatric conditions, medications that will be affected by the SIP induction. You know, it makes sense in maybe Surrey where that level of complexity or concurrent use and familiarity with what clinically happens after you give someone phenobarbital, that experience is there. And so I advocate for a phenobarbital protocol to be developed there if it's not already. I haven't worked at Surrey yet. But here, probably not. Anything online?
Nope.
Yes.
Get a patient with pause less than 4, what would you use for your guidance?
Just repeat the question.
Oh, if I had a patient with a pause less than 4, what would I do for the phenobarbital? For the gabapentin?
If you
Yeah, I've used it quite a bit. Actually at Detox here at R2R and at BDC, I use it very commonly. And yeah, I've started to use it quite a bit more towards the tail end of my fellowship. Unless there's like a history of someone seeking out phenobarbital or concerns with level of consciousness, or like a pause that underrepresents their risk of complicated withdrawal, such as like a recent severe seizure, or recent admission for benzo-resistant withdrawal in isolation of any other things on the pause score, then I wouldn't use gabapentin. But in most other cases, I typically will put people on gabapentin. I put them on like 300 milligrams TID for the first few days of their withdrawal. And then we have a discussion about, you know, how effective is this therapy going forward? There is also some literature for, like in that systematic review, to say that, and more recent, there's a 2020 paper that looked at gabapentin for use in alcohol use disorder, and people who responded to it upfront typically had better outcomes, less high-risk drinking, less readmission for alcohol use disorder and withdrawal. So it has a role, including in the alcohol use disorder population. And I think it should be used more commonly for alcohol withdrawal management than in the less severe population. And I think we don't utilize it as much because there's a fear of it masking someone heading towards seizure. That wasn't really borne out in this systematic review. And in the literature that I've looked at to date, there isn't that signal for high rates of seizure in people that we don't expect to seize. But that is always a concern. But I think we should use more. It's a long way of saying I think we should use more.
Right. We have just one last question that we'll
Great.
take from the chat, if you just want to read that one out.
Were hospital length of stay controlled for pre-existing medical conditions? Let me remind myself. Sorry? Yeah, I guess it was randomized, yeah. Well, I mean, I think both of the, why isn't this working? Both of the studies that looked at hospital length of stay, oh God, this will take a long time. Is there a better way to do this, Shannon? I'm lost.
Trial, I don't think they did any.
No, I think they're both retrospective analyses. And that's a good question. I actually can't recall if they controlled for comorbidities. Oh, I think in the MINDS, yeah, you know what? In the MINDS protocol, I do actually know this. In the MINDS protocol, I don't think they did. They actually didn't list much in the way of their patient characteristics information. Oh my gosh, sorry guys. Here, I mean, these are the demographics and the patient characteristics they looked at, which, you know, there's very little that looks at concurrent comorbidities. They mostly look at things like race and insurance coverage and you know, physical exam characteristics up front. Severity of illness, I think, was assessed by the Q-SOFA score on admission. So no, not for not for the mines protocol, and I don't believe that they did for the Liadal paper either. Yeah, I don't think they did. But thank you. I wish I had a better answer for that.
Right, thank you, everybody. That's the end of our what's new, and this is the last what's new of this year. So we'll see you again in September for the next one.
Oh, sorry.
And just a reminder to please complete the evaluation. And then there's lots of food, so please take it back to your office. And work. It was really good.
Thank you. It was nice surprise set for the.
And you have much less time. So
Yeah.
not be able